to discuss more issues related to physical or mobility changes that occur as people age. And I pulled this definition of biological aging. It's not a very happy definition, but I think it kind of encompasses some of the changes that occur. So aging is a complex biological process in which changes at the molecular, cellular, and organ levels result in progressive, inevitable, and inescapable decrease in the body's ability to respond appropriately to internal and/or external stresses. So we've been talking to date about some of the changes that occurred in the sensory system. So we started talking about, for example, the eyes and the changes in terms of the lens and how that may affect ability to see things near, how it may affect the way we see the world in terms of coloring, how it may affect our ability to see things in the periphery. And we were talking about those changes and how they may impact technology development. Today, what we're going to talk about more is changes in the musculoskeletal system, and so how mobility issues may affect our technologies and things that we need to be thinking about. So biological aging, we talked about the fact that most of the changes that we see as part of the aging process don't occur until the 50s or 60s or even 70s when we are talking about changes in the sensory systems. But biological aging actually begins around the age of 20. So most of us in here are probably have been on the upswing and now are starting the downswing in terms of biological aging. But those effects of biological aging don't appear for a long time until after this process actually starts to be in place. And there are a number of reasons for that. One is the fact that many of our body parts have reserve capacity. So let's think about the heart, and let's think about exercise, for example. The heart can actually pump up to 5 times the amount of blood through the heart. Our respiratory system, for example, can pump about 6 times the amount of air through it. So those are ways that our body has reserve capacity that allows us to compensate for some of these biological changes. The other thing is that we can use compensatory strategies themselves. So if you're having a bad day in terms of your exercise, what's one thing that you might do? Anyone? Not do as much? Maybe walk instead of run, right? So those are some ways that we can adjust or we can compensate, or that people do compensate as they get older for some of these changes that they may experience. Now, one of the things about the biological aging process is that these changes can increase the possibility for injury and accidents. And this is of concern because we know that these accidents or injuries, like a fall, for example, are one of the things that can put us on that trajectory towards functional dependence and needing some sort of assistance from other individuals. We've also talked about the fact that there's a lot of variability in the aging process, and I actually like this graph because it demonstrates a number of different ways that we can see that variability. So for example, different people can start showing changes in their heart at different times. Or, for example, the heart of 2 different people could deteriorate at different rates. So one person's heart starts to have difficulty before another. Or there's 2 different structures in a person's body, the heart and the respiratory system, and those could actually age at different rates. Or if we took an average, we could see the average of one person's biological systems declining at a faster rate than another. Or again, all these different structures within ourselves could have different rates of aging, and then just the changes in terms of the trajectory that we see in that last graph. Okay, so today we're going to talk more about the musculoskeletal system. So being able to get around is very important in terms of one's own functional independence. So being able to get oneself to the store, or being able to walk outside to get the mail, those things are all important to maintaining independence. And our musculoskeletal system is really what provides us that stability that allows us to get around. And we're going to talk about some changes that occur to all 3 of these different aspects of the system. So the muscles, which are hooked onto the bones and also the joints. And we're going to see kind of the changes that occur with aging, some of the disease processes that are associated with changes, and then also talk about how these changes in mobility may actually affect everyday independence. So the muscles themselves, here we see decreases in the amount of muscle tissue and the number and size of the muscle fibers. I had some data, and that's not there. Okay, so in terms of the muscles themselves, one of the things that happens is that there are muscles that contract fast and muscles that contract slow. And it's the muscles that contract fast that are most at risk, which means if you think about a fall, you need something that's going to be able to adjust very quickly, right, to support you in terms of making that adjustment for a fall. The muscles themselves, for smooth movement, we have muscles like we have the bicep that allows us to contract, and then the tricep that allows us to bend. So we get that smooth movement, and that smooth movement is also important in helping us in terms of preventing injuries. So just in terms of losing muscle mass, that loss of muscle mass can put stress on the knees, for example, or other joints, and that stress then can increase our risk for falls, can also increase our risk for things like arthritis. Muscle strength, again, peaks in the 20s, so 20s to 30s. Now the good news is that by about age 70, we only see about 20% loss in muscle mass and 40% by age 80. We know that regular exercise can maintain or increase the strength of our muscles. And so in addition to when we talk about cognition and the role of exercise, same thing for mobility. Exercise is extremely important for helping us to maintain that muscle mass. And in fact, some people, kind of question, is it really aging or is it disuse? So there's a lot of data that suggests that even if we start exercising when we're in our 80s, that can have some good functional benefits for our musculoskeletal system. And a lot of these changes in terms of the muscles tend to be more severe in the legs, and again, that may have impact for falls too. Okay, so what about our bones? The biggest issue with our bones is osteoporosis. So we'll talk about that in just a minute. But our bones lose bone tissue, they lose bone density, and as we get older, the amount of bone that's actually reabsorbed exceeds that's formulated. So our bones in our bodies actually undergo complete changeover every 10 years or so. So each of your bones is going to get a complete makeover every 10 years. But as you get older, that amount of bone that you're using to kind of formulate your bones is not as much as what's coming out. And so that's why as we get older, our bones become more brittle. And so it is going to be important to keep in mind things that are good for bone health as you get older. But again, our bone mass peaks at about age 35. Bone loss tends to accelerate in the 50s and then slows by about 70. So if you're a woman, this is a risk factor for you right here in terms of bone loss. And in fact, the data suggests that women lose bone mass about twice as fast as men do. And there are a couple reasons for this. Most women have less bone mass to begin with than men, but also it's thought that the depletion of estrogen around menopause has a significant effect on bone loss. So around that time of menopause, there's some data to suggest that in the 5 to 7 years afterwards, women will lose about 15% of their bone mass. So basically what happens is that our bones become more hollow and porous. So we have this very hard layer on the outside of our bones and then a different sort of softer layer inside, but it's still very, very important in keeping our bones very hard. So when our bones become more porous, that increases the possibility of fractures. And also one of the things that puts older adults more at risk is the type of fracture that they have. So younger adults have more splinter type fractures. So I guess the best way to picture this is to think about a tree branch. And if you have a young tree branch and you break it, it's very different than if you have an old tree branch and it just kind of snaps in half. So that's more of what happens with the older bones. They'll snap, and then that makes it more difficult for them to heal than when you have kind of a more splintered process. Okay, so osteoporosis, the term actually means holes in the bone. So if this is kind of a normal healthy bone, and you can see kind of the architecture of it, you can see bones affected with osteoporosis become much more porous, and then that's going to affect the strength of the bone. So there are about 12 million Americans that have osteoporosis, and you're going to see that 9.1 of them are females. So that leaves 3 million who are males. So you can see that big disproportionate difference in terms of males and females with osteoporosis. Now, the biggest culprit is the decrease in content of calcium in the bone. So calcium is very, very important to bone development and to reducing the chances of osteoporosis. So about 65% of women over age 60 and nearly all women over age 90 have osteoporosis or have some difficulties with their bones. And again, this is going to put people at risk for these falls and these fractures. And there's some data that suggest that if an individual falls and ends up in a nursing home, that 50% of those will pass away within a year. So falls and ending up in a nursing home because of brittle bones can have some really significant healthcare consequences. Things that we can do for prevention, calcium and vitamin D, trying to build up that bone matrix. Weight-bearing exercises are also very helpful, and then maintaining adequate levels of estrogen. There are a number of risk factors, so if you smoke, if you use alcohol excessively, if you have a lifetime low calcium intake, if you're sedentary, so again, exercise, if you're white or Asian, that puts you more at risk. If you're female, that puts you more at risk. If you have a small body frame, that puts you more at risk. Things like eating disorders where you're not getting your right nutrition puts you more at risk. So there are a number of things that do put you more at risk. Okay, so that's bones. And then the last area of the musculoskeletal system we'll talk about are the joints. The joints are, those areas that allow us to move in different directions, our bones. And the biggest thing there is the cartilage that's in between the joints. So the cartilage is kind of this protective sheath that allows our joints to move, and we don't experience our joints rubbing against each other. Now, how many of you know an older adult that has arthritis? Okay, so basically what's happening there is many times that cartilage has worn down, and so these bones are rubbing against each other, and that causes pain. And over time, it's going to cause extra bone matrix to be kind of occur in the joints, and then the joints can become enlarged. And the biggest thing that can happen in terms of the joints is that it can really affect mobility. So the range of motion that a person is able to engage in a particular joint. Now, if you are an athlete and are involved in repetitive movement, if you're doing some sort of manual labor that requires the same movement over and over, that can put you at risk for osteoarthritis as you get older, because again, it's that wear and tear on the joint. And in fact, arthritis is considered a wear and tear disease. So the more you use those joints, the more you're going to be kind of wearing down that cartilage. Okay, so how can these changes in the bones, in the joints, in the muscle affect people's movement as they age? one of the biggest things is that it increases movement time. So examples would be by about 30 to 60%, which might mean 50 to 90 milliseconds. So if a person's falling or has to get out of the way of some sort of danger, that 50 to 90 milliseconds could make a big difference for them. Some of the places that you might see it are things like slower handwriting, slower grasping for a glass of water, having to make more corrective movements when they're grasping for things. There can be decreases in force and output. So again, these things can all affect the initiation and the control of movement, which can put people at risk for difficulties in their everyday lives. So some of the everyday effects that we can see are things like decreased stature and stoop posture. The data suggests that women will lose about 1 inch in height. No, women will lose about 2 inches in height, and men will lose about 1 inch, yes, between the mid-50s and the 70s due to kind of the compression in the spine that occurs as people age. We've talked about the reasons why we can see increased risk of falls. We can see those broken bones. And the hip fracture is probably the most feared because hip fractures and hospitalizations are a very bad combination. Those can have high degrees of morbidity for older adults. Slower movements in walking, increased stiffness and unsteadiness, decreased stamina, and all of those things are going to affect our ability to carry out everyday tasks. So even something like turning a doorknob, or how many of, maybe some of you have this difficulty, but how many have seen like an older adult trying to open a jar, right? And I've been in those positions where, I want to make spaghetti and I can't get that jar open, right? That's very annoying. You can imagine if that's, happening over and over. So again, some of these assistive technologies, things that we can think about that take into consideration or assist with some of those mobility difficulties that individuals have. So let's stop here and think about what we've heard in terms of mobility and think about implications for design of technology. And let's just think about like an input device for a computer game, for example, or for even using a computer, or for using our digital memory notebook. Okay, so if we have a touch screen, for example, and they have to touch the screen somewhere, we don't want to have it so small that they're going to get really frustrated because they're going to be hitting targets that they don't want to hit. And in fact, we just had this issue come up with our smartwatch that Brian was showing me last week, where the smartwatch has a very small screen on it, and if we tried to stuff all the buttons, which we had wanted to do on the one screen, it would have made it too difficult for them to just press the button that they wanted. So we had to figure out how to, first of all, make the question big enough, and then to show them how to scroll, so with bigger buttons so that it would be easier to press. So very good point. Okay, very interesting. So we're going like more high tech here. So ways of maybe using things like Google Glasses or augmented reality to assist older adults in more easily locating items, for example. Okay. So when you're creating the devices themselves, be taking into consideration, let's say, maybe if we're using an accelerometer, right? And it requires a certain amount of direction or force or, I don't know, mobility angle. And if an older adult can't reach that, then it may not work accurately, say, on an older adult. Okay, good point. Okay, so there are actually mice out there that are made specifically for older adults, so for more comfort. And then what else? Also, like the mouse speed itself, right? Like you can set the mouse speed so it's really fast or it's slower. So you may want to find that slower speed that's going to be comfortable for an older adult. Okay, good. So really good examples of some things that we need to take into consideration when we're thinking about the input devices that we're having older adults use with these different sorts of technology. Okay, let's talk a little bit now about how we measure motor functioning. And then we're going to talk about some newer ways, and we'll talk about the RANCE article in terms of looking at motor functioning. So the typical ways we'll measure it, let's say we have an older adult who comes into our clinic and we want to know what their mobility is like. We can give them some questionnaires, or we could do an interview with them, and we may ask them questions like, can you climb the stairs without losing your breath? Can you walk a quarter of a mile? What are some other examples, guys, from some of our questionnaires? We might ask about their grooming and dressing, and can they do that comfortably? So there's a number of different things that we can ask individuals that will give us an idea of what they're able to do in terms of their motor abilities and everyday functioning. But what are some of the difficulties with those types of questionnaires that we might give? And we've talked about these before with research methodology. Okay, so the first thing that we're assuming is that the person has good insight into their motor abilities, right? And that, let's say, if we saw them over a 3-week period, that they might be able to notice that there were slight changes in their mobility, okay? So that's one of the things that we're having to assume, that the person has good insight and could detect slight changes in their motor ability that might be suggesting that there's some health problem. Okay, another thing that we could do is we could give them standardized tests while they are visiting us in our lab. So one that we like to do is called the timed up and go test. And we have someone sit in a chair, then they get up, they walk 10 feet, they turn around, come back and sit back down in the chair. Or we could test their balance. So we could have them hold a pose for a certain amount of time. So there are different ways that we could look at their mobility. Now, what are some issues with our clinic-based tests that we give? Okay, it's not the person's actual environment. So what if they actually have to walk around in a home environment that's very cluttered, or that has rugs, or that has a small dog walking around, right? We might not know that when we're having them walk in our clinic and saying they look like they're walking pretty well. We're also just getting that walking at 2 points in time, right? And our tests themselves, they have measurement error. So, you know, a difference between a 13-second and a 14-second might still put a person in the normal range, but maybe that difference in seconds translated to a small decline over time could have a different health implication. And so we may not, well, we wouldn't have access to all that information, right, just in the clinic. So what are some alternatives for studying movement? And this is where some of the technologies that we've been talking about and that the RANCE article talked about come into play. So one of the things that we can do is have people wear wearables, right? So we have our actigraphs, and we have our smartwatches that we're having people wear, and they have accelerometers and other ways of, you know, sensing the direction and the force and the extent of information that we can get. There's also sensors that can be put in shoes, for example, to look at gait, or to measure different aspects of gait. Now, these wearable sensors all require that they be on the person, right? So this is something that we're going to have to ask the person to put on and to make sure they're using. The other thing about wearable sensors that we have to keep in mind too is that many of these need to be recharged on a regular basis. So our smartwatch, for example, can last 12 hours, right? So we have them switching out, might last longer, but you know, to make sure it doesn't drain on the person, we're having them switch out morning and night. Our actigraphs or our Fitbits, well, our Fitbits that we've used, they lasted about 2 to 3 days. Our actigraphs, we can get about a week's worth of data. So these wearables are still things that do need to be charged on a regular basis, and they have to be put on the person. So that's one sort of kind of other sort of sensing technology. Another one is to use sensors in the environment. So we don't require people to do anything. We put the sensors in the environment. Maybe we use something like a Kinect, and we try to see if we can capture aspects of a person's mobility with those sensors. So what are some of the advantages that you guys can think of? And I know I have them up here, so that's fine. But what are some of the advantages that you can think of in terms of being able to use these sort of wearable or these in-home technologies versus kind of our questionnaire or our clinic-based assessments? Okay, so we don't have to worry about insight because we've got objective data, right, that's coming from people in their real world environment. So we don't have to kind of predict what we think is happening in their real world environment. Okay, good. Very good. So we have continuous data. And in the clinic, you know, again, we could see a person at one time and see them at another time. It might look the same, but maybe we get them on a bad day and a good day. But with continuous data, we can see that trend, that variability, and we may see like an overall downward trajectory or an overall upward trajectory. Or maybe it is staying the same, but having that continuous data would provide us with a richer amount of data. Okay, very good point. So, assuming people are not cheating, but that is something that, yes, you're right, would need to be thought about. Now, maybe with the motion sensors in the environment, that might be a little harder to do, but you could still conceivably have a person, I guess, waving their hand around, right? I don't know. But yes, that's something important to keep in mind. They didn't put it on the dog, right? get a whole bunch of activity. Okay. So maybe if they weren't using it continuously, but let's say in a clinical intervention, we said, oh, we want to get like 2 weeks of data on this individual. So we asked them to wear this technology for 2 weeks because they know they're wearing the technology. That may be an impetus to try and actually do better. Okay, so very good point. So yeah, I have advantages here, but you guys brought up some issues that really probably need to be thought about, especially if you are using them, for example, for a short time in intervention, that people are not, you know, having that bias of having the technology on itself or trying to kind of cheat the system and look a little bit better. Okay, so very good points